Welcome to Anam Cara Caregiving, where our mission is to help clients stay in a home environment as long as possible as they age and approach the end of life. The goal of this video is to help all of you as caregivers to help perform this mission while keeping you and our clients as safe as possible. Caregiving can at times involve risks for the client and for the caregivers, and we want you to have the most up-to-date information available to help keep yourself safe and to prevent injuries with our clients. I am Jeremy Wilsbacher, a certified professional ergonomist with a master's degree in engineering focused on ergonomics. I've been working as an ergonomics consultant for 18 years, supporting companies in their efforts to help prevent and reduce musculoskeletal disorders. Over the years, I've worked with many healthcare organizations as they implement strategies to reduce the injuries that occur to their nursing and CNA staff. You may or may not be aware that nursing occupations are one of the highest risk occupations in our country. Nurses and CNAs regularly perform physical tasks that we would never allow employees to do in a manufacturing or industrial environment. But it's also one of my favorite environments to work in because the opportunity is so great. The tasks are very high risk, but there are also now well-established evidence-based solutions. Through my work, I've obtained the Safe Patient Handling Professional Certification from the Association of Safe Patient Handling Professionals. Today, I'm providing this information to Anam Cara caregivers on a voluntary basis to help support you in keeping yourself safe. Many of you, or some of you, have likely had training on safe patient handling in the past, which may or may not have been based on the latest evidence and best practices. In my experience, I often find that even large, well-established healthcare organizations commonly have out-of-date content that sets up caretakers for failure and injury. Training often is focused on body mechanics and proper lifting techniques, which, as I will show you, cannot prevent back injuries. So if you've been through patient handling training in the past, I ask you to bear with me and see if you might gain some new insights from the information I will be sharing. I've helped many healthcare organizations shift their approach to up-to-date strategies. It is not uncommon for nursing homes or hospitals to see an 80 to 90% reduction in nursing injuries once they've implemented an effective safe patient handling and mobility program. Now, you'll notice in the title of this session that we're calling this Safe Patient Handling and Mobility. This is the latest title of the industry movement around safely moving patients. The addition of the term mobility was deliberately included to put emphasis on the growing body of evidence that shows that using safe patient handling equipment can greatly improve patient mobility goals in addition to keeping patients and caregivers safe. The goals of providing this information is to empower you to understand the latest research related to patient or client movement and to protect yourself. I will review a bit about the history of patient handling related injuries, risk levels, and then the current best practice solutions. I'll share a critical explanation of how back injuries develop, one of the mechanisms by which they develop, and then demonstrate which types of tasks can be high risk. We're going to discuss how equipment has been shown to improve patient or client mobility levels, and then I'll introduce you to some mobility assessments or tests that can be used to determine the best methods for moving or transferring clients. Before we get started, I do want to acknowledge that in almost every case where I have worked with clients, the caretakers, often nurses and CNAs, are often resistant to changing the way they move patients initially. The old ways of moving patients or clients are typically very ingrained in nursing and caretaking culture, but those old ways are the ways that have led to nurses and CNAs having some of the highest injury rates in the entire country. And once they do adapt to the use of safe patient handling equipment, they become comfortable with the new methods and often subsequently will refuse to work with an organization that does not have a solid safe patient handling and movement program. Of course, our first goal is to make sure that you have the best information possible to prevent yourself from getting hurt while working. Similarly, we want to do everything we can to avoid a client fall. Appropriate use of patient handling equipment has been shown to drastically reduce patient or client falls. Another result that is surprising to some is that patient handling equipment has been shown to be extremely effective in facilitating early mobility, for example, after a surgery, or maintaining mobility levels. This has at times been hard to adapt to, especially for physical therapists and occupational therapists who are used to their traditional methods for promoting mobility. But like nurses and CNAs, once they've gotten used to how to use the equipment to facilitate mobility, PTs and OTs have become huge advocates of the safe patient handling tools. Ultimately, patients and clients also end up feeling much safer when using the lift equipment as compared to being assisted manually as they make transfers. So we're going to talk a little bit about some of the history of patient handling, some of the trends that occur in the nursing industry. So a few data points to really put this in perspective. Surveys are done on nurses on a regular basis, and these are some common results that we see. And these are really sad, in my opinion, because the people that get into nursing are usually doing it because they're really passionate about taking care of others. So we see that 12% of nurses leave the profession every year due to back injuries. So every year, those people who are passionate about taking care of others have to leave the work because they can no longer perform these tasks. 52% of nurses report that they have chronic back pain. 30%, nurses use 30% more sick leave every year due to back pain than the average employee. And 68% of disabling injuries that are reported by nurses are due to overexertion injuries from patient lifts. So there's a drastic impact on the industry and on these workers that you can see in some of these statistics. In addition, in my work, we often track the trends of what occupations have the highest rates of injuries that are related to ergonomics risk factors. And pretty consistently, the 6 of the top 10 professions at risk for back injury are healthcare related and nursing related. So nursing aides or CNAs are almost always at the top of the list. LPNs, RNs, health aides, radiology technicians, and physical therapists. So we fill out 6 of the top 10 jobs that get back injuries simply due to patient handling risk factors. So this is having a significant impact on caregivers around the country. And therefore, we want to make sure we do our best to give you the information you need to protect yourself as best as you can. We're not going to look closely at these charts, but I just wanted to point out these are charts from the Bureau of Labor Statistics that collects data on every occupation in the country. And you'll see that the incident rates and the number of cases of injuries for nursing assistants and registered nurses are frequently in that top 10 list of the highest rates of injuries. And then in particular, when you look at musculoskeletal disorders, which are the type of injury that can occur from these patient handling tasks, nursing assistants are almost always near the top of the list. And I think it's relevant to look at the company we're in here. Firefighters, emergency medical personnel. These are occupations where the work environment cannot be controlled and there's often extreme urgency involved. And so the fact that our nursing assistants are right up there with them in regards to incident rates for MSDs, musculoskeletal disorders, is really a shame. And fortunately though, we are shifting quickly, and many organizations in the healthcare environment are moving towards these new evidence-based solutions. So that's a little history on the reality of injury rates. Now I want to talk about one of the most important mechanisms of back injury that occurs. And this is really critical because it's not obvious and most of us are not aware of how this works in our back. So one of the ways that back injuries occur is through damage to the spine, to the discs in the spine. And there's a couple nuances about the disc that make this particularly problematic. The first one is that there are no nerve endings in these discs. So when you do damage to the disc in your spine, there's no feedback that you get saying that you shouldn't do what you just did. You may get a strain in your muscle every once in a while if you overexert, but you're not going to get direct feedback from the disc. And the disc is where the worst kind of damage is happening. So what happens in the disc is this. You're looking at, on the right-hand side there, the top view of a vertebra and a disc. So there's a membrane between the disc and the bone. And that membrane is what allows nutrients to flow between the bone and the disc. So that's how that disc stays healthy is that there's a flow back and forth of fluids through that membrane, and the nutrients come from the bone. So the discs do not get their nutrients from blood flow like the majority of the body. So the health of that membrane is really critical for the health of the disc. So what happens is when you perform a lifting task or a pushing exertion or any kind of other forceful exertion, an amount of force travels through the spine and through those discs. If the force exceeds a certain limit, then that membrane is going to tear. It's one of the weak points. That's the first place where the damage will occur. So that's what's simulated with those little red squiggly lines on the bottom. Now, when that damage occurs, of course it will heal, but it's going to leave scar tissue in its place. So every individual exertion that you perform that goes over a certain limit might leave a scar on that disc, or is going to leave a scar on that disc. And now, of course, if you can imagine over the course of your lifetime, the more scar tissue you have, the more restricted the flow of nutrients is going to be into the disc. And so over time, we end up starving the disc. And then that one time when you bend over and pick up a pen or perform any other random task, you blow a disc, and then you know it big time. Up until that moment, you may not have had a clue what kind of damage you were doing to your spine, but when your disc bulges and it touches the nerve in your spine, then you're going to know big time because you're going to be laying in bed for days. And that's the real shame about this system, is that we don't really have those early indicators that there's anything happening. Now, research has really helped us in this area. NIOSH conducted some studies back in the 80s and 90s. They actually used cadavers and applied forces to the discs to figure out when does this damage start to occur. And what they found is that this kind of damage occurs when about 770 pounds of force passes through the disc. At that point, some of us are going to have that kind of damage. When the force gets up to 1,430 pounds, then that damage happens to all of us. So we have a couple thresholds to work with. And our goal, of course, is to keep the forces below 770 pounds. Now, that might sound like a crazy amount of force. It's a really high level of force. But I'm going to show you how we calculate that. We're not going to get into all the calculations on this diagram, but basically what I want to point out is that when you hold an item, say a 20-pound box, or maybe you're supporting the leg of a client, for example, at that distance in front of your body, think of the spine as an axis. It's like a teeter-totter. If there's a weight on one side, there has to be a weight on the other side to balance it. So something has to be pulling downward on the other side of the spine to keep you standing upright. Otherwise, the force of that box would flip you over and pull you down onto the floor. And so what exerts that force is the muscles of the spine. So the muscles of the spine, of course, are right next to the spine. And so that lever arm is very short. And so the force times the distance on each side has to be equal. So in this case, to balance that 20-pound box at a distance of 12 inches in front of the spine, the muscle force is going to be 120 pounds of force. So both of these weights are adding additional force to the discs of the spine. So in this case, in the bottom right, you see it says CF, 140 pounds. That's the compressive force on the spine, is an additional 140 pounds. Now that's well below the 770. So in this case, we should be safe for most workers. Now the problem occurs when we shift our body position holding that same weight. So now we lean over. Now imagine you could be leaning over a bed, helping to lift someone up into a seated position. You could be helping them roll. You could be lifting them in a wheelchair, etc. But when we get into this position, now we're not only lifting the weight of the item, in this case a 20-pound box, but now our body weight is leaning forward, and so the muscles of the spine have to exert force to counteract the body weight as well. So without getting into all the calculations, holding this 20-pound item at a distance of 25 inches requires 850 pounds of muscle force. So you add that muscle force to the 100 pounds of upper body weight to the 20-pound box. Now in the bottom right-hand corner, you have 970 pounds of force going through the spine. So right there, we went over that limit of 770. So some of us are going to experience that scarring on our disc as a result of that task. Now, it's not going to occur to all of us, but the hard thing is that we don't know who's going to have the damage at 770 and who can withstand up to 1430. And so our goal is to really make sure that nobody's performing tasks where that force will be over 770 pounds. Now, of course, you're going to ask, how do we translate that into reality? One of the things that I do frequently in my work is use a biomechanical modeling program where we can simulate a body posture, and then we measure the forces that are required to perform certain tasks. We input those forces into the model, and then it actually calculates what the force on the spine would be. And this is from the University of Michigan. The tool is. And so in this case, I've modeled a few tasks to give you a few examples here of the kind of tasks that are going to get over that limit. So in this case, you have two people pulling a patient up in a chair, and each of those caretakers are only supporting half of the weight, and it's not always the entire weight of that patient. But when we measure that force, we put it into the model, we find that the force is 1,063 pounds on the spine. So that's way over the 770 pound limit. So a lot of us are going to be experiencing that damage to the spine. And unfortunately, we're probably not going to have a clue that it's happening because there's no pain that we're going to experience as a result. Here's another example of helping a patient up while laying in a bed, getting them up into a seated position. As you can see with a lot of these models, the body positioning can be really critical. So body mechanics does have its place, but the problem is that most of the time we're not able to get into a safe position to perform some of these tasks. So you can do the modeling for males, females. In this case with the female, the pressure on the spine was 1,094 pounds. So again, significantly higher than the recommended limit. Even rolling a patient over. So this was a case where, I measured the force to roll a patient up onto their side, and it was about 65 pounds. And that's when two people were helping. And so when we model a pulling force, which you can also do with this modeling program, the force on the spine was 895 pounds in that posture that you see right there. Now, in some cases, you're going to have access to a hospital bed that can elevate the patient or the client. And so think about the difference of using that function or not using it. In the bottom, the bottom example here, you're leaning forward, bending over the bed, rolling that client over, and we're above the limit. If you elevate the bed, like in the top example, and now you're in a more upright standing position, now we're below that limit. So some of these little differences really can make a difference. And so the key here is really to think in every task that you're performing, if you're using any of your own physical strength, every inch counts and every pound counts to get us closer to remaining below those limits. A lot of research has been done in these areas. Ohio State University, University of Michigan are some of the leading universities that have led the research on ergonomics and patient handling. And over again, when they do their analysis, they find that there really is no safe way to lift or transfer a dependent person, even if you're using two people. And so this is a big shift in mindset for caretakers that have spent perhaps a career manually transferring patients. And many people will get through an entire career without an injury. And I would say that they're the lucky ones, because as you saw, 12% of nurses, and that's nurses, not CNAs, leave their job every year because of those back injuries. And so if you've made it, you've been lucky. That's really the only way to see it. And so one of my goals here is to really point out this evidence and dispel some of the myths related to patient handling that have been standard practice. This is a publication from the American Nurses Association. They've taken a lot of the information that was initially developed by the VA in Florida around patient handling and really have been promoting these best practices. So I want to address a few of them. The idea that body mechanics can prevent patient handling injuries. The reality is that just using body mechanics is not going to get us there. These forces that are going through our spine are still going to be above limits in the majority of the typical patient handling tasks. Another thought is that using patient lift equipment can feel impersonal. At first, sometimes caretakers and sometimes patients or clients can be hesitant to use the equipment, but after getting used to it, and it doesn't take a long time to get used to the equipment, on both sides, the caretakers and patients and clients typically find that they actually feel more comfortable, feel more respected, and safer while using this equipment. And so another piece too is that patient outcomes have been proven to be much better in regards to falls for sure, injuries, skin tears, and the fact that the equipment helps us move patients more often. So bed sores and that kind of thing are often reduced as well. Another thought, this is another challenge that I run into frequently with a lot of caretakers, is that the smaller, lighter patients, I can move them, so why would I use the equipment? I can lift them up, I can transfer them, I can support them while changing their clothes, etc. One of the really important pieces to understand is that they're actually probably the more dangerous situation because you can perform that task. And the forces going through your spine are still going to often be well above those limits that are recommended. And NIOSH, under the direction of Thomas Waters, a researcher, did a bunch of research on this a few years back. And they looked at, what would be a safe limit for typical patient handling tasks. And they said that under ideal conditions for patient handling, no one should be exerting more than 35 pounds. And so if you have a 35-pound weight, lift that thing and see what it feels like. And you shouldn't be performing tasks that require more than that amount of exertion when you're moving patients around. The other myth is that, sometimes there could be some reality to this, but systemically saying that it's a lot faster to move a patient if you just do it manually. Typically, this is an issue of equipment availability, comfort with its use, etc. And over the long term, getting help from other people, if you're going to actually try to do the task on your own, there can be a lot of other factors that can slow you down. And of course, what I find with bigger organizations is that as their employees get injured, which almost always happens if they don't have a program in place, you're losing a lot of the productivity and time that you would have had otherwise. So the point I would make is that it's worth taking the time. If it adds a couple minutes to that transfer, that's well worth your time and for the safety of the client. Another concept that people have is that I'm really physically fit, I'm strong, I've never had an injury, and therefore I'm fine performing this transfer. This is actually a dangerous mentality because often those caretakers are more likely to do certain tasks on their own, do tasks in a more awkward posture, take on more lifting because of that strength they have. But strength doesn't eliminate that risk to the spine. A lot of bodybuilders have back injuries in their spine because although they have the strength to perform a task, they're still doing that damage to the disc. And so you really want to be careful if you find yourself in that category. And then the other myth is that the majority of the time manually lifting doesn't result in injuries. The problem is, again, like I mentioned before, is that we get away with it way too many times. Not too many times. I wish we could get away with it more often. But we get away with making these manual transfers over and over and over again, and therefore it reinforces the belief that these injuries won't happen to us. But what happens is that we are creating this micro trauma in the spine, and that the cumulative impact of that is going to one day potentially lead to a pretty significant injury. And so we want to be proactive and try to avoid as many of those exertions as we can. Now, I recognize that in a home environment, we're not always going to have the best solutions available. But if we can have that mentality that every one of those awkward or heavy exertions that I can avoid is significant. It's all adding time to my back and the time that I'm going to survive before I have some kind of a back injury. And hopefully it never happens. So equipment-based patient handling solutions have been used for decades now. They've been proven out. Industry guidelines have been developed. These solutions have been proven over and over again in the past couple decades. Audrey Nelson from the Veterans Association, the VA in Florida, was one of the early champions in this area. Her work and that of her successors has really laid the groundwork for the rest of us. And over again, healthcare organizations have been able to implement programs that have drastically reduced their injury rates. Lately, the American Nurses Association and the Association of Safe Patient Handling Professionals have taken up the reins to lead the dissemination of these best practices. And the work has generally, early on especially, been focused more on hospitals and long-term care environments, since those are the environments that see the highest injury rates and perform so many patient handling tasks. It's also true that those environments do present a greater risk than working at home, simply due to the fact that they're performing a lot more of these tasks. But in the home environment, the same challenge exists, and you may not be performing those tasks as often, but the level of risk with each one of those tasks is still there. And so we really want to focus on the goal of being aware of which types of tasks can present a risk, and then work to develop the best solutions we can, whenever we can, to reduce the long-term risk of having a back injury. Advances are being made for the application of these solutions in the home environment, and they're very similar to those that are applied in other healthcare environments. But that said, it certainly can be more challenging when it comes to having access to all of the right equipment, options, slings, etc. So therefore, we at least want to understand what the best practices are and strive to implement them as often as possible. And again, I'll keep repeating, remember that every one of those exertions that we can avoid that could potentially cause disc damage is adding life to our back and avoiding a cumulative trauma back injury. The evidence also shows that these solutions prevent injuries for caregivers, increase mobility levels and help maintain mobility levels for patients, and reduce the risk for the client, which is really important as well. We don't want to have a client fall because we're trying to hold them and we have a back injury and we both go down. And so these kinds of solutions can really be effective at keeping the client safe as well as yourself. There are some simple mobility assessments that have been developed that can help us verify what type of equipment is most appropriate for any given situation. And I'll walk you through those just to introduce them to you. I did want to give a little bit of context in regards to ergonomics. So the science of ergonomics is about designing the work task to fit the capabilities and limitations of the workers. When we look at lifting in general industry, under ideal conditions, lifting something close to your body, no twisting, no bending, no forward reaching, NIOSH has determined that 51 pounds is the maximum limit. And as you deviate from those ideal conditions, that recommended limit goes down. With patient handling, that recommended limit is 35 pounds. And so the challenge is that in healthcare and caretaking, the average weight of a person, is 180, 200 pounds. And so if we're trying to lift them or support them, even if we're only holding half of their body weight, we're going to likely be above those recommended limits. So why do we really want to focus on this? I think we've hit on some of the key points already, but it's really important for client safety, trying to prevent falls for our clients. Just as important, taking care of you, the caretaker. And in our current environment, a lot of our clients and patients are larger, heavier, have a lot of other health complications, and we have an aging workforce. The average age of nurses was 51 years in 2017. So we have older aging workers who have performed a lot of these manual tasks throughout their life. And so these solutions can really go a long way to keep the workplace safe for those workers. All right, what are some of the high-risk patient handling tasks? You've seen some of them already. Think about what tasks you encounter as you're performing your work. Any task that requires over 30 pounds of lifting force, pushing force, pulling force would likely fall in that category. Other situations where we might be exerting force, especially if our body's in an awkward posture. So some common things we want to be thinking about, chair-to-chair transfers or bed-to-chair, think bed-to-chair, bed-to-wheelchair, wheelchair to toilet. Those kinds of sitting-to-sitting transfers are a common task at home that can be really high risk. Helping someone walk. So ambulation assistance, trying to prevent them from falling, and of course, if they fall, helping them up. Those are all, well-documented high-risk tasks that cause a lot of injuries in the industry. And there could be others. So with this information, keep your eye out for the kinds of things you're required to do and talk to us about anything that you feel uncomfortable with. So how do we protect ourselves? The bottom line is that when a client changes in regards to mobility needs, there may come a point when we start to use equipment. Okay, and so there's a lot of research that's been done on this. This is a screenshot of one of the algorithms developed by the Tampa VA that were really the pioneers in this area. And the algorithms tell us when we need to use what kind of equipment. And these have been really, really effective in changing the world of caregiving in regards to reducing injuries. And so they really can effectively tell us what the right protocol is in each situation. One of the challenges with the algorithms, though, is that they often will depend on you knowing, for example, when a patient can bear weight, or can they balance while standing, or does the patient have upper body strength? So the algorithms tell us what to do under all circumstances, but not necessarily how to assess the patient's status in regards to those capabilities. So in recent years, last couple of years, a lot of organizations have been working on mobility assessments. And the idea with a mobility assessment is to have a quick way for a caregiver to assess the patient's mobility level right in that moment. Banner Health did some early work that has really evolved into one of the standard practices. And this example here of the assessment tool, this comes from Hillrom, the patient handling equipment manufacturer. The mobility assessments are really great at testing the mobility level of the patient and then direct you to the appropriate patient handling solution or equipment based on that mobility level. So I'm going to introduce you to these tests. This is basically so you know that they exist. If you are interested in learning more about these or having further training on how to perform these, certainly there are a lot of resources online, or you can reach out and we can give you more guidance. But I want you to be aware of how these tests work, just to give you an idea of how objective these are and how they're designed to really test where a client is at in a given moment. So there's 4 levels of the mobility tests. Level 1, the first task is a sit test. Can the client get up from laying down into a seated position? Okay, and so if they're able to do this, it shows us whether they have balance and core strength while sitting forward, while sitting up. If they fail this test, then they're considered fully dependent. And we're going to either use a full body lift, or if you have a sit stand that has a waist belt and leg slings, but something that's supporting their whole body. The second test for level 1 is a reach and shake test. So you have the client reach across their midline and shake your hand. And this test assesses whether the client has balance and upper body strength. Do they have physical awareness of where their body is in space? If they fail this test, again, then they're dependent, and we want to use a lift that can support their entire body weight. The value of knowing upper body weight is that that's ideal if we are going to be using a sit-stand lift. Now, if they fail both of if they pass both of those tests, if they pass them both, then you move on to the level 2 tests. If they fail those, then they're considered dependent. But if they pass, the next test is the stretch test. You have them stretch a leg forward until it's straight at the knee. Now, this is simply testing whether they have adequate leg strength to stand. And if they were going to try to stand independently, they need to be able to pass this test with both legs. And so you can see the correlation. If they can't pass these tests, we don't want them to try to stand. Or we don't want them to try, to get up if they can't even lean forward in the bed, for example. And so these are pointing us towards the type of equipment we can use. If they fail this test, we want to use a full body lift if they can't bear weight on any leg. If they can bear weight on at least one leg, then a sit-stand lift can be appropriate. The next test for level 2 is called the flex test. So you have them flex the toes upward and downward. You have them do it with both feet. And so what this tells us is if they have flexibility in the ankle and stability to get into that standing position. And so we want to make sure that they can pass this test before we have them try to stand or walk. even if they were using a cane or other assistive device. If they fail this test, then again, we want to use a full body lift if they can't bear weight on one leg. If they can bear weight on at least one leg, then the sit stand could be an appropriate solution. Level 3, if they pass level 1 and level 2, the next test is the stand test. You simply have the client stand up in front of the bed or in front of the chair. They can use an assistive device if they typically do, and then we ask them to stand there for 10 seconds. And the idea behind this is that they can stand in a safe environment where if they start to not be able to stand or lose balance, they can just sit right back down. But we want to make sure they can stand for 10 seconds. It's a very simple test to validate that they can stand. If they fail to be able to get up on their own, then we would want to use a sit-stand lift. The next test would be the step test. We ask the client, if they do perform the standing test, we ask them to march in place. So now we're at level 4. This is where we test for independence. Ask them to march in place. Again, you're in a safe environment. They can easily back down onto the bed or chair. So they basically stand right in front of where they were sitting and they step in place. This test tests if they have the ability to stand and walk. One of the things you want to pay attention to is whether they are clearly stable. So you want to observe how stable they are before they perform the step and return test, which is the next one. If they show any sign of instability, we want to go back to the chair, back to the bed. And then if they can't do this test, then again, we're going to stick to the sit-stand lift. And then the last test is the step and return test. After you step in place, you have the client step forward and then return to the original position in front of the chair or bed. Repeat that with both legs. To be considered completely independent, they should be able to perform this without using any kind of assistive device. So this tells us if they have the ability to stand and walk safely. If they fail, again, we go back to the sit-stand lift. If they passed, then we consider them independent and they can move themselves and we stand by for support. But you can see that going through these tests, once you get used to doing them, it doesn't take long at all. And you can do this in any moment when you have a question or a doubt about the person's mobility level, and then be able to make better decisions, whether that is going to get equipment or maybe making a request that equipment might be required, or even getting assistance. So this is a real simple process that can help us. If you want more guidance, please let us know. There are resources online, so if you have access to any kind of particular lift equipment, you can look online and there are lots of tutorials on how to use that equipment properly, and so you can get a lot of further education in that area. So in summary, I just want to highlight that manual client movement tasks where the client is dependent, can't help assist with the move, are mostly going to be high-risk tasks. And we want to make sure that you are taking all the precautions you can to protect yourself and to protect the client. Most often, you will not feel any symptoms, even when damage is occurring to your spine. That's really a critical thing to keep in mind, that a lot of us do damage to our spine throughout our life, and we don't realize it until that one day when we get a herniated disc, and then we know it big time. And so we want to make sure that none of you ever get there. So think about it in that context, that every one of those exertions that you can avoid, both at work and in your personal life, these things cross over. There's no threshold of, just having this damage happen at work or at home. So even in your home life, be thinking about these types of exertions and try to prevent any of those as much as you can to delay that type of cumulative trauma. And so, to really close up, we really want to encourage everyone to work as a team to make sure that we can all stay safe as clients' needs change, especially. And so we encourage you to reach out if you feel like you need to perform a task that you do not feel safe performing or you feel like might be a concern based on what you've learned today.